Top Med Talk.
Nick Harrison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
Professor Bobbie Jean Schweitzer. Dr. Bobbie Jean Schweitzer completed her training in internal medicine and anesthesiology, and she is a professor of anesthesiology and director of perioperative medicine at Northwestern University in Chicago, Illinois. She is an author of the editor of Preoperative Assessment and Management. She has authored over 40 peer-reviewed manuscripts and lectures nationally and internationally on perioperative medicine topics. Dr. Schweitzer is also a fellow of the American College of Physicians, a founding member of the governing board and past president of the Society of Perioperative Assessment and Quality Improvement, on the board of directors of the Society for Ambulatory Anesthesia, and an elected member of the Association of University Anesthesiologists. She is an executive editor of Anesthesia and Analgesia Practice, and on the editorial board of Anesthesiology and Anesthesia and Analgesia. She is a host of monthly podcasts for anesthesiology. Dr. Vince D'Antini from Alfred Hospital in Melbourne. Dr. D'Antini is a senior staff specialist in the general medicine and nephrology at the Alfred Health, and also the head of our perioperative unit. Professor Imogen Mitchell. Professor Mitchell is the Dean of the Australian National University Medical School and senior staff specialist in intensive care at the Canberra Hospital. She was previously a senior medical advisor at the Australian Commission on Safety and Quality in Healthcare. During this appointment, she was able to undertake large multi-center study on the dying process in patients and evaluate the perceptions of dying by healthcare professionals. These data will help inform hospitals on where to improve end-of-life care, both locally and nationally. Professor Mitchell has also overseen the implementation of a rigorous hospital-wide clinical review process and a patient deterioration system. Prof. Mitchell was awarded a Harkness Fellowship in 2013 and 14 at Johns Hopkins Bloomberg School of Public Health, studying health systems and health policy. The first few questions go to Prof. Schweitzer. Now, you mentioned about your excellent pre-op clinic and intervention that you have offered. The first question is, what is the definition of high-risk patients in your clinic? And what is your referral criteria that you use to pick up these pre-op patients? I mean, you can't possibly be seeing all the referrals. So what kind of selected group of patients that you would recruit into you would pick up into your clinic?
So we use a variety of tools. We have an electronic medical record, and so we have built in a method with an algorithm that takes the problems and the medications and comes up with a formula and suggests to the surgeon that this patient needs to have an in-person visit or a phone call, or they can be managed with a chart review. And then that's one mechanism, but some of our patients are referred, or the surgeons that are using that are part of our team don't have the electronic record. There's a small percentage of those surgeons. And so we have some paper-based guides that is based on a comorbid conditions, medications, and surgery. But it's the person has to. We highlight certain comorbid conditions and certain medications and a certain number of medications, again, that calculates a referral or a recommendation for that kind of referral. And then we have a series of questions. If somebody needs some help, they can call this sort of hotline number and they can ask some questions. Well, my patient has this or this or this. What do you recommend? Every surgeon has the prerogative of sending their patient to us if they want, because they maybe have a gestalt. And then we also try to do this secondary screen. So, for example, if the patient was scheduled for a phone visit, then when the nurse gets on the phone with the patient, if she figures out that that patient's more complicated, then she will make an appointment for that patient to come in. And then we do chart reviews for those patients that aren't captured by those first two mechanisms. And then we will reach out to the patient directly, either to set up a phone screen or a in-person visit. So I don't think there's any perfect system. There's a lot of different ways that people have used. And we're in the process of tweaking our system, gathering data, and trying to figure out the best way.
Thank you. The second question is, in your pre-op clinic, what comprises or who are in the multidisciplinary team, and how long does each patient appointment last?
So the last question is easy to answer. It lasts too long, at least according to the patients. We try to get our patients out between 45 minutes and 1.5 hours. That includes everything, including we do on-site chest X-ray, on-site ECG, and on-site labs and urine testing. And we have some point-of-care testing that we're implementing, such as A1C testing and things like that. The easier patients, which again, everybody that should be coming to the clinic are higher risk, so nobody's really straightforward. But the easier patients should take 45 minutes or less. The more complicated patients, an hour and a half. We have hospitalists in our clinic. We have advanced practice nurses. We have RNs. We have medical assistants. We have a lot of clerical staff. And we have residents in training and medical students, and we have attending anesthesiologists every day in clinic.
Thank you. Another question. There is a lot of interest on pre-op treatment of anemia, iron infusion, and EPO administration. The question for, do you give iron and EPO regardless of whether the patient has renal dysfunction, ferritin level, or transferrin saturation level? And what is the hemoglobin target or ferritin and T-sets target that you're aiming at?
We give iron to patients who are iron deficient, and we use a category of a T-sat of less than 20% and a ferritin of less than 30%. Either one of those is sufficient to make that diagnosis of iron deficiency, because ferritin is an acute phase reaction. It can go up inappropriately, so it shouldn't be used alone, though ferritin is probably the absolutely best test to assess iron deficiency. One just has to realize that you can have a falsely elevated level. And then there's categories of functional iron deficiency. And those are with patients who have ferritins of less than 800 and with T-sats of less than 50%. And those patients are the ones who typically have a component of chronic disease. And those patients are probably best treated with IV iron and erythropoietin. So we have a protocol where we will give those patients one infusion of IV iron and one EPO, and then we monitor their reticulocyte count and their hemoglobin levels to see if they increase a certain amount before we decide to pursue that further. Iron deficiency anemia, absolute iron deficiency anemia, is an absolute number. There's formulas you can use to calculate how much the patient needs. So we don't give them iron based on a ferritin level. We don't give them iron based on where their hemoglobin's going. We give them iron based on what we calculate their iron deficiency is. And so we use a Ganzoni formula. You just Google Ganzoni. If you send me an email, I'll send it to you, our protocols. And then we just treat that. The only people we avoid giving anything to are those who likely are not going to benefit, and those are patients who truly have iron overload, and that's usually demonstrated by T-sats of greater than 50% and ferritins greater than 800.
Thank you. And there is also a bit of interest about using pro-anti-BNP, and what is your experience, for what do you know about using the point-of-care BNP analyzer, point-of-care test, and can you comment on the cost-effectiveness?
We don't have a point-of-care BNP, so I don't really know. I can't comment either than what I've read in the literature, which I think, the future is point-of-care testing. I think it just comes down to how accurate those tests are. I think that, no test is going to be perfect. And one has to weigh how fast you get the results, what the overall cost of that is, and whether, again, it can be used as not necessarily in of itself an absolute test, but again, another mechanism to triage patients, for example. Because if a patient has a normal BNP, and most institutions have that test available to them, and it's a cheaper test than the NT-BNP, which is a terminal fragment of a BNP. You can use that to help you sort of take the next steps and start to, guide you along a pathway. Because the problem becomes is when you've got a patient with an elevated BNP. And again, you need to go back to, I think, then they just lump them into two separate categories now. And not every patient with an elevated BNP needs to have further testing, or it doesn't necessarily tell you specifically what's wrong with the patient. It just tells you that patient is very different than the patient has a normal BNP. And as far as cardiac prediction, I think the data is quite strong that you can stratify patients into low risk based on a normal BNP.
Okay, thank you. The next set of questions goes to Dr. Diantini. If the patient is on multiple antihypertensive, what is your practice like? Do you withhold all the antihypertensive, or you selectively withhold ACE inhibitor and ARB, or how do you prioritize?
So in one of the studies, I presented the number of antihypertensives was independent risk factor for a bad outcome. I tend to, a lot of patients nowadays are on at least 2 or 3, often a diuretic attached to one of the ACEs or ARBs. I tend to still give the calcium channel blockers. I think that's still in the guideline. And certainly beta blockers with ischemic heart disease. And I still focus on ACEs or ARBs as the one that I withhold on the day of surgery in my practice.
Thank you. The next question is, can you comment on the impact of perioperative non-steroidal anti-inflammatory use or COX-2 inhibitor use are in the prevalence or incidence of acute kidney injury, especially in the elderly patient?
If you really want to kill off a nephron, you make it dry, you have an ACE or an ARB on board, and with a diuretic, and then throw a non-steroidal in. I have to say, but I'm nephrocentric. So look, they are. I mean, they are fantastic analgesics. They're very, they get, you get a great result from their analgesia, I believe. So I don't mind using them, but I just don't use them if there's a chance that, the glomerulus is at risk, and i.e. there's going to be long surgery, blood loss, potential for hypovolemia, and certainly an ACE or an ARB on board. I certainly don't use it, and throw in some contrast. That'll be, the final nail in the coffin for the kidney. But if someone's on a calcium channel blocker, surgery's gone well, their volume's good, and anti-inflammatories are going to be useful in their multimodal analgesia post-op, I certainly wouldn't be against it.
Yeah. So at the beginning of your presentation, you mentioned about a few risk factors, traditional risk factors that may predict chronic kidney disease and also acute kidney injury. The question is obesity in itself a risk factor for acute kidney injury?
To be honest, I don't know. I don't know. There's bigger patients do better on dialysis as dialysis patients. I think I understand bigger obese patients do better with cancer, I think. So I'm not going to sort of say that...
They do better if they end up in a nursing home too, apparently.
Do they? Okay.
Yes.
Well, yep. So on that theme, I'd say no. Well, you're on a winner.
Yeah. And the last question to you, Vince. Does single intraoperative dose of gentamicin increase the risk of acute kidney injury?
No.
Great. All right. For the next set of questions is to Prof. Mitchell. First question, should anaesthetists be more involved in the post-op HDU care for higher risk patient, or is it the ICU's role?
I'm an intensive care doctor. That's a bit like your turf war with perioperative medicine, I imagine. Physicians, anaesthetists, intensive care doctors, anaesthetists. I think intensive care would say that their specialty is critical care, therefore should be involved. But that's not to say that, to be honest, it probably just depends on your resource, what you have available to make sure the patient's safe. Whoever has those skills and your organisation, the way it's constructed.
Sure. I think along that line, I'm not very familiar with this model of care because I'm not an anaesthetist, but the question is Toronto model of PACU HDU a possible solution to immediate post-op for high-risk patient?
I mean, again, I suspect what will happen is depending on how your hospital is set up, what skill sets you have will then depend on what you need. I mean, right now for us in Canberra, we have virtually no intensive care beds, stroke HDU beds. So I suspect our anaesthetists are chomping at the bit that they would like to have better management of those patients in their recovery area.
Mm. And what do you think of the extended stay recovery?
See, I keep saying the same thing. Depending on the resources, there's never a right or wrong because otherwise I'll be politically incorrect. Yeah. It's really making sure that whoever has the skill set to manage these patients will be the best for the patient. I mean, I'm obviously an intensive care specialist who will say that intensive care is the right people, but I will never refute the fact that there are other people out there who can manage patients.
So the next question is, as a result of your trial, there is actually an increase in number of med calls in many hospitals, and in fact, at the Alfred we have got 7,000 med calls a year, which have become a bit unmanageable. But there's reduced deaths in cardiac arrest, etc., and reduced unplanned or ICU admission. But what is the evidence for the med call system out there that you can comment on?
So perhaps just to comment on our own data is that since that study, the little before and after, which always has multiple issues, our intensive care admission rate has just skyrocketed. So in fact, our percentage of elective surgical admissions has gone down because presumably elective surgery has changed in its nature, become much more or less invasive. And the number of patients coming from the ward area has almost doubled, I just think, in 10 years. So in spite of my data, it suggests that intensive care admissions have gone up. And what was your other bit to the question? The evidence.
Evidence, of the med call system.
I think you will find that over time that these rapid response teams have probably made an impact on patient outcome.
Yeah. Thank you. And this is going to be the last question. There's no one from the audience. So we know that the one-off observation leads to med calls, recognizing the deteriorating patient. But can you comment on the trend of the vital signs being important part of recognizing the deteriorating patient? What is the practice and evidence out there in not relying only on the absolute values within the med call criteria, but just looking at the overall trend?
Well, I'm sure the delta is quite important in terms of rate of deterioration and that they have got worse. I think the only thing I'd say is I probably may not be able to admit this in public, which of course is now being recorded, is I think the vital sign deterioration is quite a blunt instrument for patient deterioration. And I think this is where it goes back to clinical experience, because you could probably have good vital signs and you know yourself that patient looks dreadful, and yet there's nothing in the vital signs that will say that. So I don't think vital signs is the only answer for patient recognition in terms of deterioration, and I think it is a blunt instrument. But if there's nothing out there at the moment other than measuring vital signs, I think we certainly should be doing it.
Thank you very much. So in the interest of time, I would like to draw this meeting to a close. Can you please join me in thanking all the speakers?
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.